Everyone, thanks, Faye. Yes, so like Faye said, I'm going to be attempting to be the Jackie Weaver in tonight's scenario. So any shouting about standing orders, we will boot you, but I will be bringing your questions to the front. So if you've got some burning issues that you'd like Professor Colin to talk about, then please do let me know. There'll be a portion of tonight's session where it'll all be question and answers. So you can either use the chat box to get your questions in nice and early, or when it comes to it, you can raise your hand and then we can give you the floor and you'll be able to speak to Professor Colin yourself. Now, this isn't my first meeting with Professor Colin Dayan. We both worked together. It feels like a lifetime ago. And I was it 2018, 2017, that sort of
17, 18, yeah.
And we put together a video about a different research project. So already, you know, that just goes to show you that research project is still going. So you're working on a few, but immunotherapy is, I guess, one of the ones that you're probably most well known for. But what is it to begin with? What is immunotherapy?
What a good question. So thank you very much. And it's a great pleasure to have a chance to chat to you all tonight. I looked down the list of participants, recognize a few, and others are really, really welcome. So type 1 diabetes is an autoimmune condition. That means that it's actually the immune system that is damaging your insulin-making cells. And what we've realized over the last 20 or 30 years is that it goes on over a long time. It probably kicks in for many people as early as 6 months after birth. But for most people, actually, it's already kicked in by the age of 5 or 6 years afterwards. Now, obviously, some people have already got their diabetes by then. But for others who are not diagnosed until the average age to be diagnosed, or the most common age to be diagnosed, is around 12. And obviously, there's a huge spread. You can be diagnosed right up to the age of 70. But during all that time, the cells of your body that normally protect you against infection are nibbling away at those insulin-making cells. So the idea is, instead of just waiting until it's all broken and we have to give insulin back, why can't we stop the immune system in its tracks? And that's what immunotherapy is about.
And a lot of people listening and watching along tonight will, like you said, already have their diagnosis. I was diagnosed on the later end of the scale at 23 or something, I guess. You mentioned up to 70, not quite the latest end of the scale, but you know, in relative terms. So this isn't necessarily going to change my condition, but the work that you're doing could help to postpone a diagnosis, and then that maybe will give us clues about the condition as a whole that we could then use to look at, you know, those lofty goals of a cure or something in the future.
Yeah, I think if you're living with type 1 diabetes now or in the family, you can look at it in several ways, and maybe we'll have a minute just to describe a bit more about what it actually is. One way of looking at it is that if you have type 1 diabetes yourself, your first degree relatives, that means your children, your brothers and sisters, have a 10 times higher risk than the rest of the population of getting type 1 diabetes. The risk is still relatively low. It's about 3 in 100, but it's higher than 3 in 1,000. But we can also, as part of the immunotherapy program, we have a way of testing you to see if you've got the immune response going on. If you're in the early stages of it, and we test for these antibodies called islet antibodies. The test now can be done on a finger prick of blood, and can be put on a card and sent through the post for people to check. If you are negative on those tests, certainly by the age of 12 or 13, you've got a less than 1 in 10,000 chance. So you can take the view that what it does is reduce the risk of your relative ever getting diabetes, not to zero, but it becomes very low. And the longer that you don't have the antibodies, the more it's never likely to happen. So if you get to the age of 18 and you still don't have these antibodies, it's not impossible, but it's very, very unlikely that you will develop diabetes. So that's one way of looking at it. And the other way of looking at it is, if you're positive, then there are things we can do about it, and we can intervene to prevent that actually happening. So I think that's one thing that we maybe could be able to chat about a little bit later on. Your family members and how that would work. We are developing also clinical trials. We can chat a bit more about that, both for people who've been newly diagnosed and for people who haven't got it yet. And if you want to contribute to the research effort, then you can take part in that. so that if you're tested, we can, help you to take part. And lots of people are taking part at the moment, which is really terrific. And then what you're doing is helping the next generation with the new treatments. If you don't like either of those two things, I'll put one more thing on the menu, which is that although immunotherapy is likely to be the first new therapy to come along, I think, that will change stop people needing insulin. But there are two other ways that people are looking at. One is to grow new beta cells and put them back in. And another way is to get your beta cells to grow again. You might think they're the same thing, maybe they're related. One is getting your own cells to grow again, and another one's putting other cells back in, like a sort of transplant or stem cells. But the worry is that in both those cases, if you destroy beta cells before, you'll do it again. So there is an advantage then in having the immunotherapies that say, well, look, number one, I'll switch off your process that's killing your own insulin-making cells. Number two, I'll make yours grow back. That is for the future. That is not something we know how to do at the moment, but it's preparing us for a future. And maybe we can help people who already have, like you, Jamie, already have it, or Faye. Can we do something to make things grow back? And I'll just put one last teaser in there, which is that there is some evidence now that many people, maybe most people with type 1 diabetes, still have a few insulin-making cells. I'll say no more about that, but I can take questions on that. It doesn't get to zero.
Well, hopefully, by will or something like that, or maybe science, we can revive them and get them working again. But it does seem like we're in a very exciting point in terms of diabetes research. For my YouTube channel and podcast, I'm covering all sorts of really exciting stories. Really at the start of their scientific development, really. You hear about Canada and curing of diabetes in mice and things like that, but the work that you've been doing for a long time, and you actually lead the Diabetes UK funded type 1 diabetes immunotherapy consortium. So explain a bit about what that is and the impact that it's having. So
immunotherapies come in lots of flavors. And I would say that type 1 diabetes is almost the last disease that they've come to. The therapies that we're mostly talking about today, the ones that are available now, are already being used for lots of other conditions, for psoriasis, for the bowel inflammation, for arthritis. They've been used for over 20 years in that direction, where, if you like, the last disease that they've come to. And one of the reasons you might say that is the case is what I sometimes call the curse of insulin, that as Faye said at the beginning, 100 years ago, it was an absolute godsend and it saved people's lives. But now people say, well, you guys don't need an immunotherapy because you got insulin. Just take your insulin and get on with it. And I think an important part of what we've been trying to do over the last few years is to get people to stand up and say, it's all very well for you to say that, but this is a real struggle and we'd much rather not have it. So what we've been doing is, and really emphasize this, not just us, it's particularly networks in Europe and particularly in the USA who've been doing all of this kind of work. We essentially run over 25 hospitals around the country, sites where people can take part in research. So we're trying to get the research done more quickly, get the answers out there, and then get the companies to actually license the drugs, because you can't use it unless the company goes to the government and says, I want to sell my drug for type 1 diabetes, can I do this? So what's happened now is that there are 7 drugs that have been shown to slow the loss of your beta cells. So if you take those, then your beta cells don't go quite so quickly. And the excitement 2 years ago was one of the drugs, it's actually been around for 20 years. If you give it to people who haven't got diabetes yet, it delayed the time before they needed insulin by 3 years. And that was just one course over 14 days. They didn't have to do anything more than that. It was a 14-day infusions. The newer drugs are probably not going to be infusions. They'll be subcutaneous injections, a little bit like insulin. That's what we want. That's a very strong direction. So we can give it to people who've just been diagnosed and keep their beta cells for longer. That's good because it makes your control much easier. But then if you identify people who don't know they've got diabetes yet with those antibodies and say, why don't you take it now? And what will happen is your beta cells, instead of, because you need to lose about 80% of them before you need insulin. If we can keep it at 60% or 50%, you don't really care. You're happy with that because it means you don't need to inject insulin at all. If you don't need insulin, you don't have to watch your diet, you can't get hypo, and also you have perfect blood sugar, so you're not going to be at risk for long-term complications during the time that you don't need it. So the idea is to just do it and then do it again and push it out again and push it out again. And certainly our group's goal in the UK ultimately is to make childhood diabetes, first of all, a thing of the past. We haven't helped you there, Jamie, but the idea is to push it later and later and later so that everybody gets diagnosed later. Eventually, there may well be treatments that you can carry on taking so that you don't ever get to that point.
And as well as the obvious benefit of delaying the inevitable, extending the time between spotting the early signs and then an eventual diagnosis, other than the obvious benefits, what were the benefits that you saw? Maybe in terms of mental health or in terms of like the family unit, and just by delaying it a few years to allow the child to become a bit more mature and understand the situation a bit better. What benefits did you see?
Well, it's really interesting. So most of that wasn't done by our group because we've been working with the newly diagnosed. And this is where I think I really love a debate to happen tonight and then across the country, because some people say, oh, I don't want my child to be tested because you're just going to upset us. And on the other hand, what the evidence showed is that, yes, of course, you are upset when you're told your child is going to get diabetes. And I would just say, if you've got 2 of these antibodies, you've got a 90% chance. It's not could be, it's going to happen at some point in the coming years. Of course, that's very upsetting. And some people with diabetes themselves say, I don't want to know that. But there's already an advantage, maybe more so in people who don't have diabetes in the family. But what we find is they don't end up getting sick. So at the moment, almost everybody who's newly diagnosed, maybe everyone on the call, ends up in hospital. They end up, nobody understands what's going on. They have weeks of people going, oh, the child's drinking a bit, but he's just moaning and he's a bit tired. And I've told him to pull himself together and he's whatever, and he's losing weight. He should eat a bit more. Back and forth to the doctors. We can show that they've been to the doctors nearly 5 times as often as other children. During that period, nobody gets what's going on. And then bang, they get ketoacidosis and they're in hospital pretty sick, and many of them in intensive care when they're little children as well. That disappears completely in people who've been tested because they know it's going to happen at some point. So when they start drinking a bit more, losing a bit of weight, immediately a finger prick and you know what's going on. That means that they can learn about it in a much calmer way. They can start thinking about the diagnosis early on. If you don't have it in the family, you can suddenly realize what it is, instead of the whole thing happening as a crash, Jamie, which is what happens for the last 100 years, that it's just, oh my God, I didn't realize that was going to happen. Now I've got to think about changing my life for the rest of my life, taking these injections. I don't understand this carbohydrate stuff and this hypoglycemia stuff. Whereas if you knew it many years in advance, then that would help. And what we see is that that although there's an increase in anxiety when they're told it, it's much less than when you're diagnosed out of the blue. And so because you're much better prepared. And so one of the things we expect to happen is that no one comes into hospital anymore at their diagnosis. Why do we need to do this? And again, I'm interested to hear what people say on the call. It's really distressing, isn't it? I mean, that's your introduction to illness is ending up in hospital. Some people say to us, it's good to have a shock, but I don't think there's any evidence that that's a good thing to do.
No, I'd agree with that. I think especially when I was diagnosed in later life, I don't think it really hit me until probably around about now, 5 years later, when I've actually sort of, during the pandemic, taken some time to reflect on what's just happened. And you're right, the treatment of diabetes and the way that people manage it, it's very reactionary. So if we can preempt some of that, it might make the whole situation a lot less like, I don't know, a mad dash to the fridge and back upstairs to the insulin and then repeat the process. But would that mean then that we're testing every child for the potential signs of type 1 diabetes?
Nothing gets past you, does it, Jamie? Yeah, that's right. So only an important statistic is that only 10% of diabetes, type 1 diabetes, comes from families. And so I'm guessing a lot of people on the call tonight, when they were diagnosed, there was no one else in the family who had it. And that is the usual situation. So if we want to prevent all diabetes, we do have to screen the whole population. That's exactly right. And we're beginning to think about it Obviously, we need the drugs to be introduced. We're hoping they will be introduced in the next year or two. And there'll definitely be more clinical trials in the next year or two for people who are at risk. And then we think about how you do this screening. So one way of doing it is that when you take your kid for a preschool vaccine, so they always go to the GP about age 3.5, have a finger prick done there, we'll tell you the answer. And obviously it'd be optional, it won't be required. That would be very good for catching about 70% of people who are going to get it who haven't got it yet. But we'd have to do something different in the younger ones. And of course, the younger you are when you're diagnosed, if you're under 5, you tend to be sicker when you're diagnosed, and it's a bigger risk. So we're actually moving to something that's already been started in the Oxford region, and actually they're doing it in Newcastle and a few other areas, which is to do, and some people may have taken part in that, do the genetics at birth. And so you can do that on the, the heel prick that a baby has. You can then look at their genes for diabetes. And that can identify people who are likely to get it, not perfect, but likely to get it in the next 5 years. And those ones will be followed more carefully. So that's an option. And I think that's the future, is that, we can look at DNA and give you predictions.
We're just taking a look at some of the comments and questions that are coming in already. A lot of people asking, where can I get this drug? Where can I take this test? And really that's, I mean, that interest is what's eventually going to help these become more mainstream. So are these trials in active recruiting?
Yeah. So you can, particularly if you're a family member at the moment, and I'm guessing most people on the call probably are a family member. So the Enodia study is studying family members, and also the Address 2 study can study family members, although at the moment it's only kind of licensed if you're you're a family member of somebody who's newly diagnosed. But Enodia, which is operating in several places around the country, we can give you information after that. You can go and be tested, and if you're positive, they'll continue to follow you up. It's part of, if you like, an observational study at this point. In terms of the drugs to prevent, we think that study will be open later this year. But if you're tested and you're positive, you'll be positive for probably many years. So you don't need to go into a trial straight away. It can be later on.
Mm-hmm. So then the applications of this, all of these things that we're going to find out through these trials, how would they affect someone like me, who's definitely diabetic, like you say, has lost 80% of their beta cells? A lot of people in the chat box here as well asking those questions. But what does it mean for me as an older person with type 1 diabetes?
I can't think of you as an older person, Jamie, but and I noticed that there was a comment earlier on from somebody who was in their 60s, wasn't there, and said, yes, I've had all this. Anne Brown, I think it was. I was diagnosed last year at 65 years of age. Has this been nibbling away since I was born? So we can look at it in lots of different ways. Well, I mentioned, a little taster to you, that you probably still have some insulin-making cells. We know this because if we measure a thing called proinsulin, this is the protein that becomes insulin. And when the cells of your body make insulin, they make proinsulin first. And weirdly, in people who've got very little insulin that we can detect, we can often detect proinsulin. And that only comes from beta cells. So it suggests that some of the beta cells are asleep, might be the right word, but they're not going all the way to make the final product, if you like. They're making half of it and then spitting it out. So it's not our specific area of research, but it is related to it, is to say, well, how can we get these back into action? And one of the things is going to be protect them from being knocked on the head again by the immune system, as I mentioned earlier on. But we're also very interested in ways we can get these to function a bit better. We are just starting, probably in the next 3 weeks, a study of a tablet that's been used for 50 years to treat blood pressure called Verapamil. And that'll be across 10 cities across the UK. This is for adults aged 18 to 45. And strangely enough, this tablet seems to protect beta cells. It doesn't make them regrow, so we're not quite ready for you yet, Jamie, but it's still for people who are newly diagnosed in the last 6 weeks. Somebody asked what newly diagnosed was. For some of the studies, it's 3 months from the first insulin injections, others it's 6 weeks. but we'd offer you to take the tablet and see if that can hold on to those beta cells longer.
And I think just from that conversation there, we've sort of sparked a bit of a bit of interest in people hypothesizing where their type 1 diabetes came from. So I wonder if we can touch on that, because I'm seeing here a lot of people thinking that something triggered their condition, and that would sort of ring true with my situation. So just moving to Bristol, getting my first job after university, you know, ridiculously stressed, you know, at the point of burnout, and then at that point I find out that I've got type 1 diabetes. So I don't know, what are your thoughts on that?
Yeah, well, I think the general belief is that it's the straw that broke the camel's back, Jamie, rather than the beginning of the story. So the idea is, as I mentioned, that, you know, you only need a relatively small number of your beta cells. It's a bit like if I take one kidney out, you wouldn't notice it. If I take 1.5 kidneys out, you still don't really notice. You need more than that loss to not be able to deal with, you know, for it to do the job. You've got spare, let's put it that, spare capacity. So in the same way, you can lose 50% of your beta cells. You can cut out half the pancreas, actually, and you don't have diabetes. So there is reserve. But when you're sick, when you have a temperature, when you have a virus infection, you need more insulin. You probably know that yourself, don't you, that you have to inject more insulin. It raises the stress hormones, your demand is more. Now, if you're right on the edge and you've only got a few beta cells left, and then you get flu or you get stressed and you've raised the stress hormones, bang, now the sugars go through the roof because now you can't cope. So it's, if you like, it revealed what was coming on for some time.
And then just to echo what Anne was saying earlier, that the sense that was this nibbling away at me for my whole life. So this is something that I often think about in the years preceding my diagnosis. Would I have been unwell, or, you know, has that time between the diagnosis affected, you know, my body's health generally? Has it done some damage?
I think we can confidently say no, because the thing that does damage is the high sugar levels, not the lack of insulin. And if you've got enough insulin to do the job, and if the sugar levels are perfect, it's not doing you any damage. So that's the good news about it. I don't know the answer to Anne's question, because what other colleagues have done, and Kathleen Gillespie's group in Barts Oxford area in the UK has done, for example, is to follow children from birth. So they start right at the beginning with cord blood and go all the way through. And they've got as far as 18, 19, something like that. A little bit older, actually, in the box cohort. It's been going on for 30 years. But they've not got to age 60 yet. So we don't really know how that's going to play out. And we think there probably are some people, believe it or not, more than half of people are diagnosed as adults. We may not realize this. And they often get muddled up with type 2 diabetes, especially when they're a little bit older. But you know, we don't really know where all that comes from. One of the things we do know is that the more genes you inherit, the younger you get your diabetes, if that makes sense. So we can now, there's over 40 genes that we monitor, and you get a score depending on how many of the bad versions of these genes you've got. Even if you get 40 out of 40, it doesn't mean you're absolutely going to get it, because, you know, as you were asking what causes it, you know, the identical twins, if you have an identical twin that's exactly the same genes as you, there's still only a 50-50 chance they're going to get diabetes. So the genes isn't everything. It's only half, maybe less than half the story. But, you know, the more of these genes you get, the younger you're going to get your diabetes.
Okay. Well, I haven't worn jeans since March of 2020. Well, so
and they were good genes.
Interesting from Rebecca, who said hers came on after some vaccinations for traveling, so that would make sense with the straw that broke the camel's back. But another one here from Rachel Bennett, who asks, her youngest son was diagnosed 5 years ago. His older brother started with an autoimmune condition. Now the hospital have agreed to test him for antibodies. If he's positive, would there be an immunotherapy treatment available to him? And I'm guessing probably not, if we're still at trial stage.
Yeah, so we are at the stage where nothing is licensed yet. Although I think the more we push and the more you push and the more DUK pushes, the more likely it is to happen sooner. Because unfortunately, there's been a view up to this point that we don't need anything other than insulin. And actually, myself and other doctors, I think, have been, guilty of this, of saying, well, it's fine. Look, we've got these fancy pumps and so on. But in fact, the levels of control have not improved that much over the last 20 years. I know that might seem a bit shocking to people. People have tried very hard. In children, it has. But overall, in the population, less than 30% achieve a target of, you'll be familiar, 7% or 53%. That has only shifted probably from about 25 to 30% over the last 10 years. So the fact that the kit is there doesn't mean everybody wants to use it or is happy using it. So I think it starts by people saying we need something more. And then we do want to believe that if the companies are pushed, they will license the drugs. And I'm saying this quite strongly because we've talked to many of the big companies and they say, well, we've licensed it for psoriasis, we've licensed it for arthritis, we've licensed it for, we're not going to bother in type 1 diabetes because no one's going to buy it. That you don't want it. The doctors say they don't want it. The patients say they don't want it. And that's why I think changing that attitude is really important, and that will make them available sooner.
So we've got to make a bit of noise, and
definitely
you guys watching along to make a bit of noise now. So we're going to open it up. We're sort of halfway through, so we're going to open it up to sort of a question and answer section. So you can, like people have been doing already, whack some questions in the chat box, and I'll pass them along to Colin, or you can use a function in Zoom called raise hand. So I think if I attempt to do it now, no, I don't know where it is. It might be on your screen somewhere, maybe if you hover over your face. So that'll be how I know that you want to ask a question. Or I think actually someone's just holding up their hand to the camera, Galaxy A20E. So I'm going to ask you to unmute because I think you've been holding your hand up for a while. So if you just click unmute, there you go.
Then you have to find yourself and then click on yourself. Then you can raise your own hand. You can't raise anybody else's hand.
So Galaxy A20E, I've unmuted you. You can ask your question.
Hello, my name's Richard Beamond from Gloucestershire.
Hi, Richard.
Now, I was diagnosed in 1959 after a tonsil operation that went wrong. And at the time, the matron there was totally unsympathetic. When I started going on injections, she glared at me and said, "Oh, you'll have to have these injections for the rest of your life." Now, I've basically endured that. A couple of years later, because of the diabetes, I also developed epilepsy. So all my life, I've just endured these injections. Now, all I'm asking, is there any hope for people like me who've had diabetes over 60 years and have basically just got fed up with it?
Yeah, very good question. I think everyone gets fed up with it many, many times over. I think you're absolutely right. So, at the moment, if you like, if you said, what could I do for you? I'm not going to say tomorrow, but we do, of course, have transplantation. We have pancreas transplantation, the whole pancreas, and we have islet transplantation as well. Now, we only use that for a small number of people. And the reason is twofold. One is we don't have that many pancreases or islets because you can't give it from a living donor, if you like. It has to be from somebody who's died. But also because at the moment, to have a pancreas transplant, you need to take pretty strong immune drugs. They have to knock your system pretty hard so that you don't reject the transplant. And that has some risks for you. And people tend to say, well, generally, if you're doing okay on insulin, it's not worth you taking that extra risk. Also, having a whole pancreas transplant is a pretty major operation. And the transplants last for about 5 to 7 years, sometimes less, sometimes more. So it's not been a routine procedure, but a couple of things that I mentioned earlier on might become available. So that's either growing your beta cells back or developing stem cells that can grow into beta cells and put those back in, and find ways of doing those with less, you'd have to take less drugs to do that. But I guess what we're saying tonight is that's a little bit behind the curve at the moment than these treatments for people who are newly diagnosed or who haven't lost their beta cells yet. Because at the moment, we don't know how to regrow the beta cells. It's better for us to prevent it rather than actually we're less skilled at intervening at your stage, Richard, if that makes sense.
Fantastic. So I'm going to work through the people who've got their hands raised. So Ziala, I think I'm going to come.
There's a few things on the chat as well, isn't there, Jamie, as well?
Yeah,
so
yes,
yeah.
We'll come back to those in a sec. We'll just try and work through the people who got to ask some questions. So Ziala, over to you.
Hi, my name's Zila. Sorry. I started reading a book called Mastering Diabetes, and it's by a couple of American guys who claim that if you went onto a low-fat, plant-based diet, you can reproduce your beta cells and stop that breakdown. But the diet is extremely rigid. You know, it's literally all fruit and vegetables and nuts, rice and grains and beans and things like that. Have you got any view on that? Is it something that you've heard of as well? Or, you know, what do you think? Is it possible to do a bit of that to help yourself, or what do you think?
Well, actually, I don't know so much about that diet, Zila. I know that a lot of people use carbohydrate restriction, which of course is the almost opposite of what you've just described. And I'm not I think you're on mute, or you're back on mute or something, so I can't hear you for a minute. Somebody muted you, I think.
Thank you. It's just what they were saying, that lots of people, when they're first diagnosed with diabetes, sorry to interrupt you, but are told to reduce their carbohydrates. So you naturally then take less insulin. But their sort of claim is that that's not the way to go, and you actually need carbohydrate in order for your body to function properly. That was their...
Yeah, no, and I would agree with that. I'm not strongly recommending carbohydrate restriction.
No.
It was the only thing, actually, 100 years ago. That's what they did. They had a sort of egg diet, and they severely restricted carbohydrate, and the kids got thinner and thinner and thinner. It was just awful. The idea that a fat-based diet could actually increase your beta cells, I don't know that I've not seen any evidence that that is being proven. Let's put it that way around. So, you know, I think that's the best I can say. I haven't seen any sort of independent research work on that, showing that that actually does work. And one of the tricky things is that the rate at which people lose their beta cells is very variable. So there are some people who 10 years later are still making loads of insulin. And there are people, usually the little ones, you know, the younger you are, the quicker it goes, who within 6 months really have nothing and you know, very, very dependent on insulin. Missing the one dose would increase their risk of ketoacidosis, that kind of thing. They're very insulin dependent. So,
okay, thank you.
Thank you for the question.
I like the sound of that egg diet. Sidra, coming to you next. Just asked you to unmute. Oh,
hi, Sidra.
Sidra, we can't hear you, or I can't at least. Oh, you're back on mute, Sidra. Oh, don't you love Zoom?
Can we unmute Sidra? There we are. You should be unmuted now, but
Sidra, we still can't hear you, I'm afraid. Do you want to type your question into the box, and I'll do the talking for you. Thanks, Sidra. Let's move on to Lucy then. Lucy, what's your question? Hello, Lucy. Oh, we're in a meeting loop now.
Yeah, I think we got it now.
I think I've got it.
Hi,
Yeah.
Lucy.
Hi, Lucy.
Yeah.
Hi. I was diagnosed with type 1 when I was 8, and I'm now nearly 18. So I was wondering about the immunotherapy drugs. Do they have a drastic effect on other processes in the body, and would they put you at increased risk of other things? Because obviously immunosuppressant drugs suppress you.
Sounds a bit scary, doesn't it?
Yeah. And yeah, what are the other effects of taking the drugs?
Yeah, so that's a really, really good question. And it's a question I especially like because people do worry. You know, when I said to, I think it was Richard, I said, you know, the drugs you need for transplants are pretty strong drugs, and they do increase your risk of infections, and they increase your risk of things like skin cancer. But the drugs I'm talking about are not those. They're the ones we use for rheumatoid arthritis. Some of them are licensed for arthritis from the age of 2 upwards. And the reason is that they're very much clever and more selective. They just pick out one little bit of the immune system rather than the whole lot. So at this point, there is very limited, there's little evidence that they have long-term side effects, possibly a slightly increased risk of things like tuberculosis if you were to get that, but not, not urine infections or chest infections, not the kind of normal thing that you would think about. And even then, this drug, for example, anti-TNF, has been around for over 20 years. When I was doing my PhD, Lucy, I told them it wouldn't work, and then they developed it, and it's been the biggest selling drug of all time. So don't count on everything I say, but it's been used in rheumatoid arthritis for 20 years, and really there's certainly no significant increase in cancer. Possibly it's debated about whether there's a slight increase in tuberculosis, but it tends to be in populations that have a high risk of TB. So these slightly odd infections, and that's the reason why you wouldn't do it for nothing. Some of the newer approaches, though, the one I mentioned for the fortnight, 2 weeks of injections. I think there's somebody on the call who's actually had that in Sheffield, 5 people treated in that way. Really, then the immune system seems to go back to normal after that. It's like it resets it. So we're trying to make it better and better. But we wouldn't be suggesting at this stage if it was worse than insulin. Let's put it that way around.
Great question. Thank you for that, Lucy. So gonna pop over to the chat box again. If you've got any questions that you don't feel comfortable asking in front of everyone, do pop them in there. It's just at the bottom of your screen. Nadia here says, hi, I was diagnosed 5 weeks ago. Welcome to the Broken Pancreas gang. And I'm interested in the project study. However, it's for age 8 to 17. I'm 18. Would there be a study like this for people my age?
And of course, the answer would be, in this case, yes. So we have studies now open from 18 to 45. So there'll be somebody with 46-year-olds just about to come on the chat. So there is a study open now called the Impact Study that you'd be eligible for potentially. So I think probably towards the end, or I can put it in the chat, so our website is type1diabetesresearch.org.uk. or search type 1 diabetes research, you should find it. And then it's got a list of trials and the trial centers where they do it. But we have a lot of people actually, especially during this time, they register on the website and they're willing to travel to different areas. So if it isn't happening in your local hospital, it may be happening in a different hospital further away, and you can travel to those things. They do, the Impact Study is wanting to be within 9 weeks of diagnosis. So you might want to get in touch fairly soon. And the new study I mentioned with the blood pressure tablet will be open hopefully in a month or so's time. That will again be 6 weeks from diagnosis.
We still have some active recruiting going on today. That's what we
like.
Yeah. One more question from the chat box, then we're going to come to you, Alan, next. Sam says, why are more children being diagnosed? My 2-year-old is 6 weeks into diagnosis. Also, can tech for children catch up? These pumps seem to be developed with adults in mind.
About 3 good questions there, really. So I think you're right that people need to think about the technology. I'm not a technologist, but I do agree with you. In fact, I know David DuPont's on here who works with us at the Diabetes Research Steering Group in Diabetes UK. We strongly believe that they could make the tech a lot more user-friendly and more people would pick it up. It was a real plug and play, easy to wear kind of thing. So do keep pressing for that. I think the question was about are more younger people being diagnosed? And the answer is yes, more under the age of 5 in the last 20 years. The belief is that's because we live in a cleaner environment. It's hard to imagine, but just about 70 or 80 years ago, half of children died in childhood from infectious disease. Now, if a child dies of an infectious disease, meningitis, something like that, people think it's shocking. So the immune system was working really hard in those days. They were exposed to infections all the time. And we think it's not so much an idle immune system that then decides to do autoimmunity, but it seems to be that we, as you again see more allergies, you're seeing more peanut allergy, things like that. That seems to be that the immune system, if you like, is less challenged earlier on by infections.
Fantastic. So Alan, coming to you now, what would you like to ask?
Hi, my name's Alan. I'm 54 and just recently been diagnosed as a type 1. And at the hospital, they said that it's quite rare. It's normally a late adolescent. And I just wondered, is there any kind of research, or, can I get my beta cells reworking? What does the future look like, really?
For you, yeah. Well, actually, it's probably not as rare as people used to think. And indeed, the group in Exeter published quite recently to say, it's more than half of the people at all ages are being diagnosed. Not half of all the people with diabetes, because of course there's loads of people with type 2, but half of the diagnoses are in adulthood. So, and in fact, the rate continues all the way through up to the age of 60 or 70. So I'm with you on that. Now, it's good to be diagnosed later. I was saying about the kids that we try and push them out, because long-term complications take 15, 20, 50, 60 years to happen, depending on your level of control. So on one positive side, if you've got less time to develop complications, if you like, than if you're diagnosed at the age of 5. In terms of treatments, as I say, it's interesting that our studies have been generally up between 18 and 45, largely because we didn't want to get muddled up with type 2 diabetes. But actually, your case flags up the fact that we really should open this a bit more. And what we're going to do is if we do sometimes the genetic tests along with the antibody tests, we can be more certain that you actually have type 1 diabetes. And I'd add one more thing to that, which is, up until recently, people didn't actually diagnose type 1 diabetes properly. They just said, oh, you look like, Alan, you look like you need insulin, you've lost a bit of weight, that's it. And if you say, well, did you prove it? Was there any test you actually did? Then the answer generally was no. And we're going to try and encourage more people to make that as a definite diagnosis. There isn't a perfect diagnosis, but if you've got the antibodies, then it's 90% certain you've got type 1 diabetes. And if you've had diabetes for more than 5 years, and you still have a lot of insulin circulating and no antibodies, it's more likely you've got type 2 diabetes. And that's important, because if actually you've got type 2, we found that 5% of the clinic in Scotland could stop their insulin because they'd got the wrong diagnosis. They didn't have type 1 at all. And then there's a lot of new drugs for type 2 that work pretty well. And, you didn't need to have insulin in the first place. So I think getting closer to the correct diagnosis, I'm assuming it's correct in you, but I'm saying that's a direction of travel, and that more and more of the studies will include you, although we don't at the moment.
Okay. And also I found that from when I got diagnosed, I'm probably taking half the amount of insulin than I did at the beginning when I came out of hospital. Is that something that is natural, or?
How long ago did you say you were diagnosed?
It was in July last year.
So like about 8 months ago, something like that.
Yeah,
7, 8 months ago.
And about 2 months ago, with the diabetic clinic, we took the dose down to 50%, and now I'm 50% -1. And it all sounds really good because I'm using less insulin, and I'm feeling okay, and my A1C is down to about 6.3. But again, with it all being new, I'm still not.
Well, it's all good, but I mentioned that mostly people lose their insulin in the first 5 years after diagnosis, but it varies quite a bit. Sometimes it's quick, sometimes it's slow. What you're telling me, if you're on less than about 0.8 to 1 unit per kilo, so if you calculate the total amount of insulin you're on and you divide it by your weight, if you're on much less than that, for example, if you weigh 60 or 70 kilos and you're only taking 30 units of insulin, almost certainly you're still making quite a lot yourself. So that's telling you that you're still making it. And it isn't that unusual to have in the first year a kind of recovery. And we believe that's because the beta cells were overwhelmed by the high sugar at the beginning. They went, oh my God, I don't know where to start. And as you brought the sugar down, it became less stress for them and they began to perform a bit better, but it doesn't stop the process altogether. We don't have good evidence that tight control makes them last longer, but it's still very good for you in the longer term. So, and every bit of insulin you have, as you're showing, really helps the control. So I think a lot of people on the call might remember that in the first year or so after they were diagnosed, it wasn't quite as tricky as it is 5 to 10 years later or 20 years later, when it's much more variable.
Really interesting. Just going to move on because we've not got loads of time left. But that was really interesting from Alan there, and a lot of people in the chat actually are just a bit concerned.
Can I select my favourite questions out of the chat as well, Jamie?
Yeah. Sure.
You go ahead.
I just want to let everyone know that Faye from Diabetes UK has said that we'll be putting this on the YouTube, Diabetes UK YouTube, I think. So if you've missed a bit because of your Wi-Fi or something like that, then don't worry, you'll be able to watch us on catch up. Colin, what did you want to say?
So there's some great comments, one from Lucy about 6-year-old daughter, thinking about more time would be good. I certainly back that up. And other people saying it's not good to have a shock. People often say it's good to have a shock, but then they used to say corporal punishment was a good thing. I'm not sure we've actually proved that over time. There's one where saying, should every baby be tested then? And then the answer ultimately would be yes. At the moment, it's only in certain areas of the country where they're offering that test to mothers. Remember that the baby test doesn't prove it. It doesn't mean you've already started, because it may not have started that process, but it tells you whether you've got a higher risk of it happening and more monitoring. There's one from Hazel about, shouldn't all GPs and the general public know about the symptoms and signs? And I think Kramer want to come in on this. We've been trying this for years, and public campaigns and so on. But you have to remember that a GP only sees a new diagnosis of type 1 diabetes every 5 to 10 years. So it's not, whereas they see coughs and colds all the time and kids losing a bit of weight all the time. So I don't think we're ever going to overcome the fact that if you take your kid who's got rather non-specifically unwell to the doctor, they're going to go, yeah, sure, we all have these things. There's a lot of it going around, et cetera, until they miss the diagnosis. So that's why I think that the testing alerts the people where it's going to happen and gets you completely prepared. One mother said to us, I couldn't prevent the diabetes, but I could prevent the DKA.
And just as you're saying that, a lot of people asking, how can I get these antibody tests? Catherine's asking about her 9-year-old and 6-year-old.
Yeah. So as I say, you've got, well, the current option is, if you look up Inodia or register on our website, we can refer you to a center that can do those tests for you. It's done, that is part of a clinical trial. So you have to kind of give your consent and they do the test, and then, but then you're included in a follow-up. So you'd have to sort of agree to doing the follow-up. It is possible, but not definite, that later on this year, it may be available through pharmacies that you'd have to pay for. It's not a standard test that you can just go to the GP and say, can I have this now, please? We hope that is going to be the future in the next years, maybe 2 or 3 years. But at the moment, it has to be part of a clinical trial, but it is available.
Then did you have any more comments or questions that you wanted to pick up on specifically?
Well, I'm just looking down actually at this because there are all these many good comments. You pick up your favorites as well, because there's so many great comments.
There's a good one here from Lauren. So from someone that's inside the research sector, what can we do on the outside as people with diabetes? What should we be using our voices for? What's the priority? Asks Lawrence.
I knew that was the question I wanted.
Oh, good.
So it was. Well, I think I mentioned it early on. I think, people may have heard me say before, I want you to get angry about not having a replacement for insulin for the last 100 years. Because as I say, it was only in November in the leading medical journal that one of the leading doctors in the US, when a new treatment, this anti-TNF, showed dramatic effects, they wrote and said it doesn't really matter because we've got insulin and most people are fine. And that's still the attitude out there from so many doctors. And of course, some patients who've done an absolutely brilliant job. They say, why do we need something else? But I think, you know, that voice of saying, I don't want my kids to get it. I wouldn't want to have it. Delaying is good. Keep it moving further out. Because remember, delaying means if you delay for 3 years, that's 3 years when your child can do whatever they like, eat whatever they like, and they've got perfect sugars. So they're actually benefiting all that time. It's not putting it off and making it worse later. It's actually giving you advantages. So I'm encouraging you to lobby Diabetes UK, as many people as you can think of, to say this is something we do want.
And then Hina has had a hand up for a while. So would you like to ask your question? I've just asked you to unmute. Hina?
Hi.
Hi.
Hi, Jamie. Hi, Colin.
Hi.
I've just typed my question. I've had type 1 diabetes for over 26 years now. I am 49. How would I find out how many beta cells I've got left, if any? And also, would I be eligible for any immunotherapy trials, or does the amount of time that I've had type 1 diabetes affect this?
Yeah. So unfortunately, the second part is that the trials are only for people who are newly diagnosed at this point in time. If you wanted to know how many beta cells or how much you've got left, the test is called a C-peptide test. Somebody asked about that further on. And the reason it's a C-peptide test, so when you make insulin in your body, you make it as one long string and cut it in half, and there's a piece in the middle that you throw away, and that's called C-peptide. And we measure that because we don't want to get muddled up with the insulin you've injected, because that wouldn't make sense. We don't want to measure the NovaRapid that you've injected. We want to know what your body can make. And that C-peptide is not in NovaRapid or in Humalog, any of those injected insulin. It's only in your own. So that's how we detect it. It's not done as a standard test, but do you remember I mentioned earlier on about the clinic in Edinburgh, in fact, who tested the C-peptide in every patient that was on insulin in their clinic and found that 5% of them still had loads of it left, and actually they could come off insulin. So there's some discussion about whether people who are on lower doses of insulin with very smooth control, should it be done? I actually feel it probably should be done on people who've never had a definite diagnosis of insulin, of type 1 diabetes, because more than 5 years afterwards, it's usually at a very low level. It's still not routine, but you can ask. When I say it's not routine, every lab in the country can do it, but it's not what doctors are doing every day. Let's put it that way.
And then just a few minutes left. So a couple of your quick takes, if you could, as brief as possible, on Dr. Faustman's study on the possibility of using BCG to treat HELP type 1.
Yeah, it's attractive, but really the evidence is not that strong. And I don't think I would encourage people to just go for the BCG option. We've got much better options available.
And what about those stem cells and those mice in Canada?
Yeah, so stem cells, people are working hard on stem cells, but you have to, I often say the best beta cells are your own beta cells. And at the moment, the stem cells do make insulin and they do switch off when sugar levels are low, but they have to do it really quickly. There's no point in something that just releases insulin 30 minutes later, 60 minutes later, doesn't release enough. These are racehorses. They have to perform really well to pump out the insulin when you need it. They also have to not have the risk of becoming cancers themselves, because sometimes when you've grown cells, there's a risk. So some of them are being put in little bags to stop them, escaping, if you like. So definitely keep an eye on that. We hope that we'll, if you like, I'd like to think that we can get you to grow your own before we have to use the stem cells. But anything that works, go for it. Keep an eye on these different options.
No, it's really interesting you sort of adding to that, because I think all the discourse in the media and all that sort of stuff, a lot of people have sort of taken that and run with it, and when can I get it, when can I get it, but actually just a little more information, then it sort of changes your opinion on it slightly. Someone asking Derek actually to repeat the kilo to weight insulin units equation again.
Okay, so the simplest one is 1 unit per kilo. If you're on 1 unit per kilo or more of insulin, then in fact, a lot more than that, you probably have type 2 diabetes actually, but or some degree of insulin resistance. So that's roughly it. If you're 80 kilos, 80 units, that kind of thing. less than half of that, it sounds like you're still making some insulin.
And just a question sort of on that same vein while we've got a minute to go. Bernadette asks, a sister with type 2 uses insulin, was gradually increased until she was on 134 units a day. We thought she must be type 1, but working with the dietitian, she lost 3.5 stone and is down to 28 units a day. Could more people be helped in this way?
Yeah, there is an overlap somehow between type 1 and type 2. Remember, type 2 is resistance to your insulin, and losing weight does actually help with that. So there are some people with type 1 who actually need quite large amounts of insulin because they've become insulin resistant as well. They've become very overweight as well. Most people with type 1 are not overweight. So I think there is, you know, what Bernadette is highlighting is that it's important to get properly diagnosed. And the C-peptide test, as I mentioned, is a way of being certain or fairly certain which type of diabetes you have, especially if you had it for some time.
It is interesting because, you know, I don't know anyone that I know with type 1 diabetes has actually had a C-peptide test to prove it.
No, they might need to nudge the doctor a bit hard, actually. Tell them to give me a call, but it does work.
And then just literally in the last few seconds, Frankie has a question. So over to you, Frankie. Oh, still muted, Frankie.
Mute.
No, you're there now, Frankie.
I just wanted to query that comment about the 1 unit of insulin per kilo of weight. Is that per day, the amount of insulin you have?
Per day, total per day.
But if you are on, I'm actually doing like sort of a keto diet, which is very, very low. And I have about 20, 25, maybe 30 grams of carbohydrate a day. So I'm automatically having less. So surely that would put me in the bit that might make me type 2, or no, not type 2. I'm producing
some, yeah. Well, I wasn't taking into account, you're absolutely right, Frankie. I wasn't taking you into account. I mean, because you're right, if you reduce your carb intake, you're going to need less insulin, and the calculation doesn't work quite so well in that situation. So I was just assuming it was on a normal carbohydrate diet.
Yeah, okay. And one question, have you done any of these trials on people like me, touch wood, who haven't had any complications with diabetes? Is there any difference in the trials you've done, people that have had complications and those that haven't? Any better results?
Well, again, a great question. Let me answer it this way. At the moment, we don't know any genes for complications. So you might think, I mean, for example, only 1/3 of people get kidney failure, no matter how bad their sugars are. Almost everybody, if you have bad sugars for many, many years, you'll get eye problems. And if you have good sugars, you don't get eye problems. But kidney failure doesn't affect everybody. We don't know why that is. The assumption is maybe it is a gene thing, or, you know, there's other factors going on. But the other interesting thing is, somebody mentioned it, I think, that we found that some people have held on to their insulin for very, very many years. In fact, in the States, in Boston, they have a thing called the equivalent of the Diabetes Medal is the Jocelyn Medal. So you get this medal if you've had diabetes for 50 or 60 years. And it seems, I don't know whether this is actually true, but it seems they said you can have this medal if you give us your pancreas after you die. That's not quite true, but they did a study on people who've had many, many years of diabetes, over 60 years after they died. And the majority of them still had a few beta cells left, which was quite remarkable. So the question is whether some people, where they don't have complications, have actually held on for longer than others. And that may be part of the story.
Well, thank you so much for all the questions. Just want to wrap it up from this comment from Peter here. He says, hi, everyone. I wanted to say that working in diabetes research, it was really nice and motivational to hear your opinions and stories, and has certainly emphasized the human element in the condition. All the best to all of you. And I think that really echoes what we hope to achieve tonight, you know, us learning a bit more, and then the people that spend their time working on diabetes get to know a bit more about us. So that is pretty much it. We are just over 7 o'clock, so I'm about to hand back over to Faye, who will do a bit of housekeeping and let you know where you can watch this later. But I just wanted to say thank you to everyone tuning in tonight. Thank you again to Colin, who I'm sure will cross paths again, Colin, and another
definitely.
some other exciting project. But if you wanted a bit more about me, I do a monthly type 1 diabetes podcast. It's called the All for One Podcast. You can find it in all of your podcast providers, Apple, Spotify, and on YouTube too. So do check that out if you're into that. But thank you so much, everyone, for tuning in and taking part. Have a great rest of your evening. Faye, back to you.
No, thank you so much, Jamie and Colin.